Welcome to the ATCM video channel. So today we are going to discuss a case of supraventricular tachycardia in a 2-year-old female child.
Okay.
So on arrival, first initial assessment wise PAT scaling. On appearance wise, child appears irritable, normal tone and crying. And regarding the work of breathing, the child has regular breathing, no increased efforts and no abnormal audible breath sounds. And regarding the circulation to the skin is looking normal. After the initial PAT assessment, coming to the primary surveys. The primary survey airway was patent, no secretions and no stridor. In breathing part, patient was tachypneic, respiratory was 30 times per minute and increased work of breathing was seen. Circulation wise, heart rate was 250 beats per minute and BP was 120 by 80. At this point, because of the high heart rate, we asked connect to the defibrillator. Cardiac monitoring was initially. 3-lead cardiac monitor was connected. And disability wise, the patient was irritable and crying.
Okay.
On the evaluation of the ECG, like on the initial ECG, we had seen that there is a absent P waves and regular RR interval and narrow complex QRS, narrow QRS complex was seen, sir. Rate was 250, sir, 250 beats per minute. So as
narrow complex regular tachycardia.
Yes, sir, narrow complex regular tachycardia with absent P waves.
Okay.
So as per this, the PALS guidelines which we have, first after securing the initial assessment and after securing the airway and the evaluating with the ECG, we found that it is a narrow QRS complex tachycardia. And the patient's vital lift BP was 120 by 80 and no signs of any hypotension, shock or any altered mental state was noticed. So it's a stable, patient is a stable kind of narrow complex tachycardia.
How do you divide tachycardias into various groups?
As such, tachycardias as the sinus tachycardia.
Tachycardia will be narrow complex tachycardia or broad complex tachycardia.
Yes. Basically, it is divided into narrow and broad. That is the first thing. Then
stability. Basically, unstable tachycardia or stable tachycardia.
Okay. So one is narrow and broad. Other one is stable or unstable. That is clinically. Okay. Unstable means what all things?
There are 5 points to denote instability. So one will be if the patient has a new onset chest pain, or if there's any signs of heart failure, altered sensorium, if the patient is in shock, and then
signs of heart failure.
Okay. So stable or unstable, narrow or wide. Third point is regular. These are the 3 things you have to see. Here it is stable patient, narrow complex, regular.
Okay. So
mostly it is
supraventricular tachycardia. The heart rate is 250 and regular with no P waves absent. And for in such a case, the initial maneuver which we should be doing is the vagal maneuvers, like putting an ice cap on the head face of the child or carotid massaging. Once if it is not reverting with the help of these maneuvers, then we can try with using the IV medications. Here in this case, the vagal maneuvers had failed and then IV access was attained and through the IV line, fast bolus of adenosine was given.
Okay.
Adenosine
not given.
Adenosine has to be given on the thing of 0.1 mg per kg.
Weight
0.1 mg per kg.
Child, the weight based calculation is required. Adult, you are telling 6 milligram.
Okay. 0.1 mg per kg is to be given and maximum dose being the 6 mg. The first dose would be the 6 mg.
How do you give adenosine? And what are the precautions you take? What are the adverse effects you anticipate?
Like adenosine, basically mechanism of action is blocking the AV node, so that it's like a 3rd degree heart block.
3rd degree.
Third heart.
It reduces the conduction. It will not produce block. It reduces the conduction.
The AV node reduces the conduction.
Automaticity and conduction is reduced. It will not produce block. Okay.
So like the way we should administer adenosine would be like a fast bolus, as because in the blood vessels, the RBCs and the endothelium has the deaminase which destroys the
half-life.
shorter
So it has got a
half-life.
very short half-life. So IV push has to be given. Some saline has to be pushed
along with
after
the
that.
fast
You have to
one.
lift the hand. 3 things you have to remember. Otherwise, it will not work, and it is very costly also.
Yes.
Okay, then what are the adverse effects you anticipate? What are the patients you are not
Adverse effect-
supposed to give it?
Basically, adenosine has
Hypotension.
contraindications, so we need to check on the patient's background history also. Like, for example, if the patient has bronchial asthma,
That is
it's
most important. Since it
Bronchial.
is a child, you have to ask whether bronchial asthma is there or not.
then any higher degree of heart blocks. Again,
Heart blocks
it
we
is
cannot give.
complete heart block or Moritz type 2 heart block, we cannot give adenosine. So in these, first we'll have to revise the patient's medical history, and then only we'll have to administer. And then after, since it's a child, then consent has to be taken, procedure has to be explained to the bystanders, and then the airway management trolley has to be always kept, because the patient
Anytime
can collapse.
severe breathlessness, and he can develop breathing difficulty, respiratory arrest, not respiratory arrest, severe bronchospasm, and patient very well can develop severe hypotension also sometimes.
Hypertension.
Okay, so we have to be very careful in this type of patients.
Continuous monitoring along with the 3-lead
ECGs.
We'll have to take an ECG both before and after the procedure.
Okay.
But in generally in adults, we'll try as you mentioned, a carotid massage or a vagal maneuver. For carotid, before attempting a carotid massage, we'll have to first place a stethoscope and rule out the possibility of carotid bruit.
Okay.
Because if at all there is a thrombus which can get dislodged, it will again lead to further complications. So once we have ruled out carotid bruit is when we do only a massage for about 5 to 10 seconds on only one side we attempt, not on both the sides.
Not on both sides.
So, but in kids, preferable vagal maneuver method is to place an ice pack on the eyes of the baby, or attempt the Valsalva maneuver. So these would be the vagal maneuvers. Most of the time, especially in kids, it will revert, but if at all it doesn't, is when we'll have to go for pharmacological reversion, wherein adenosine comes in play. But in kids, both for stable and unstable SVT, we prefer adenosine, which is again given in the dose of 0.1 milligram per kg, first dose with a maximum dose of 6 mg.
Okay.
And the second dose is given at 0.2 milligram per kg with a maximum dose of 12 mg.
Okay.
So this is how we manage the pharmacological aspect in pediatric age.
Okay.
That is different from the adult. In adult, if it is unstable, we go straight away with cardioversion.
Okay. And amiodarone also can be tried in adult.
If at all adenosine is contraindicated or if it doesn't revert, is when we prefer a second line agent like amiodarone. In kids, it will be given in the dosage of 5 milligrams.
Okay.
Regarding like the algorithm wise, when we see a sinus tachycardia, we divide it in two conditions like stable and unstable. And in stable, again, we divide it as a narrow complex and wide complex.
It is not in stable or unstable. It is basically divided into 3 major categories. Stable or unstable is for our treatment purpose.
Yes.
So in an unstable patient, if you give a beta blocker or adenosine or whatever it is, it can produce further destabilization of patient. Patient may develop hypertension, shock and all. That's why we have to avoid such drugs in patients who are unstable. But stable means we can try drugs first, then can go for other things. Okay.
So like in a narrow complex stable condition, which can be the differential for the paroxysmal supraventricular tachycardia, there if there is an IV access already present, we can go for adenosine or the vagal maneuvers initially and then the adenosine. And if it is a wide complex tachycardia with the stable condition, then we go for a synchronized cardioversion.
How many times you can give adenosine?
Twice.
Basically 3 times you can give 1 6 mg, maximum dose of 6 mg, and the second dose has to be maximum of 12 mg. So you can repeat it as 0.2 mg per kg with a maximum of 12 mg.
You have a central line?
In central line, it will be half the dose because it is very close.
Directly. Push it. So central line you have to give half the dose only. Okay.
And in the unstable conditions, when the narrow complex and the wide complex tachycardias, in unstable narrow complex, we would go with synchronized cardioversion. And if the wide complex also, it would be a synchronized. Adenosine can be even given in children with wide complex also.
Okay.
After that, synchronized cardioversion.
What are the reasons for wide complex tachycardia?
Ventricular tachycardia. VT.
Wide complex tachycardia reasons.
Reason?
Bundle branch.
Can be regular or irregular.
It can be SVT or VT.
SVT with
complex.
aberrance.
It can be regular or irregular. That is again secondary.
Secondly, so if it is irregular, then it will be dorsal
Hmm.
pointus or it will be VF.
Hmm.
If it is regular, then it will be SVT with aberrancy or it can be
If the
VT.
patient is saying atrial fibrillation with LBBB with tachycardia, it will be irregular.
Irregular.
So basically, they are divided into two important conditions. One is wide complex tachycardias can be either due to VT or SVT with aberrancy. In SVT with aberrancy, there are three conditions. What are the three conditions? SVT with LBBB, SVT with RBBB,
SVT with
W. So these are the three things. Only in one condition in SVT, these drugs like beta blocker, calcium channel blocker, all these things are contraindicated. What is that condition? WPW. Okay. So otherwise, any conditions, if you know that patient is having SVT with wide complex tachycardia due to RBB or LBB, can safely give all these drugs. Unfortunately, most of the doctors who do duty in emergency room, they may not be able to pick up. That's why ACLS or PALS say that in a patient who is having wide complex tachycardia, go for a Medron or a shock or whatever it is, not beta blockers. But if you know the patient is having a SVT with LBBB, you can safely give your adenosine or beta blocker or calcium channel blocker. Okay, continue.
Like it was reverted on the first dosage of the dosage itself. It was reverted, and then the child was put on the beta blocker propranolol TID dosing and was discharged.
Okay, then she improved. What was the reason for tachycardia?
So the reason was being an underlying chest infection.
Okay, hypoxemia. Maybe hypoxemia or infection related tachycardia or myocarditis.
No, sir.
Something has to be there, no? Either severe hypoxemia can produce all these problems, tachycardia can be there, or severe sepsis, infection, myocarditis can produce, or viral myocarditis itself can produce all these complications. Without that, suddenly nobody will develop this type of problem. Other important problems are drug-induced, like we are giving a lot of cold medicines like phenylephrine, pseudoephedrine, cough suppressants, salbutamol. All these things can also produce tachycardia, supraventricular tachycardia, atrial fibrillation. So we have to take a detailed history of what he has taken. Otherwise, this child will be branded as a cardiac patient afterwards. So we need to know why this tachycardia is occurred, either due to infection, sepsis, drug-induced, whatever it is. Congenital disorders are like they need to have continuous. So they may have to like monitor how even after that patient heart rate, everything has to be monitored. Anything else you want to add?
So basically, it's very simple. So we just, whenever the patient has tachycardia, we see if it is narrow or if it is wide. And if it is narrow, we see whether it is regular or irregular. So if it is regular, we see whether there is P waves or there are no P waves. If it is P waves, which is more common in children, it will be a sinus tachycardia.
Yes.
So the reasons more often will be reversible causes. It can be because of pain, infection, if the patient is running temperature, the baby is running temperature, any of these, or the baby
Normally,
is
because of all these things,
hypoxia.
heart rate may not be 200, 300. It may go up to 180 in children, but 250 and all will be mostly either due to drug-induced problem. They might have taken cough suppressants.
If there is no P waves and the rhythm is regular, in children we take the cutoff as more than 180. In infants we take the cutoff as more than 220.
Okay.
So these would be the standard heart rate.
Is child or infant?
Child, so two.
Child.
For children it will be more than 180, infants more than 220. So without P waves, regular rhythm will be SVT. So that will be managed with vagal maneuver, doesn't repeat, then with adenosine. Both for stable and unstable, all we do is give adenosine, which is unlike in the adults. Now coming to the other aspect wherein it is irregular, wherein P wave will be absent and it is irregular, then it is AF.
Okay.
Now coming over to the white complex, again regular and irregular. Irregular, like we mentioned, it will be VF, causality pointers, or AF with any
AF with tachycardia with LBV or RBV.
We will have white complex irregular tachycardia. For regular, it will be only two options: either it will be VT or it will be SVT with evidence. So these would be the major classification on how we go about it.
Okay.
In unstable patients, we don't need to really sedation like in adults actually.
Okay.
So in emergency situation, we can directly go synchronized cardiovascular even if the child is unstable. So we
Okay.
can start with 0.5 to 1 joule. And again, if it's not reverting, but the next time we can increase it to 2 joules per kg.
Okay.
But also in pediatric, except for like irregular white coat in all other cases, we can give a trial of adenosine. We can give bone one and then again bone two also, but if not reverting, immediately go for synchronized cardiovascular.
Okay.
But either way, before and after the reversion, ECG has to be taken.
It has to be taken. We have to follow up because some of the cases it can revert back to tachycardia. We cannot shift this patient to ICU. We have to give we cannot shift the patient to ward. We have to keep this patient at least 24 hours in ICU itself just to monitor the heart rate. What happens if the heart rate is very high, like
250.
250 and or
There,
continuous?
there is no time for there's like
That is
ventricular filling.
hypotension can occur. Diastolic phase can. In child, if the heart rate is very high, like this, like that for some time, at least 1 or 2 days, if the heart rate is very high, what will happen? Cardiomyopathy can occur. Dilatation of ventricle can occur, and it will become a lifelong problem. Like unlike adult, it's a growing phase. Child will have long-term complication because of that. So we have to control the heart rate. Okay. Thank you.
Okay.